This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome, everybody, to another episode of PHM from Pittsburgh. I am your host, Dr. Tony Tarchichi. We are still coming to you from UPMC Children's Hospital of Pittsburgh here at the Paul C. Gaffney Division of Pediatric Hospital Medicine. For those of you who don't know me, I'm a MedPeds trained pediatric hospitalist. We have been doing this podcast since about October of 2016, so it's been a little while now. This is part of our special series for the PHM National Conference. This is part of our leadership series. And for those of you who may not be familiar, we did a special group of podcast episodes for the PHM National Conference for when you're there and you want to listen to something that maybe you missed a conference, maybe you missed a lecture, and you want to hear something in your hotel room. We made a special group episodes for those at the request of the section on hospital medicine, which we were happy to help out with. This is part of our leadership series. As with everything we do, this will have CME credit from the University of Pittsburgh, so thank you, University of Pittsburgh. So without further ado, I would like to introduce my guest for our continuing talk and conversations on leadership. I am very fortunate enough to have with me today Dr. Tom Nichols. Dr. Tom Nichols is the Vice President of Medical Affairs for St. Elizabeth Hospital in Appleton, Wisconsin, a community hospital with 140 beds that serves adult and pediatric patients. He has oversight of the medical staff and work on quality, safety, patient experience, and regulatory compliance. Prior to that, Tom spent his career as a pediatric hospitalist with the Children's Hospital of Wisconsin and Mayo Clinic, working in community pediatric hospitalist sites. He got into leadership in 2011 and has held roles as medical director, regional medical director, and department chair with the Children's Hospital of Wisconsin, and served as co-chair of the AAP section on community pediatric hospital medicine. Through his work for Children's Hospital of Wisconsin, Tom helped expand the program from one site to 3 and saw a dramatic improvement in financial performance and physician engagement and quality improvement in work. So there's no wonder we asked him beyond. We're very happy to have him on. Tom, thank you very much for joining us.
Thanks for having me, Tony. I'd like to tell you that I'm a longtime listener, first-time caller. I have listened to your podcast for the past couple of years and really enjoyed it, so I was flattered that I was asked to participate.
Well, I appreciate it. You're the first person to ever use that, a long-time listener, first-time caller. That's great. So, Tom, let's start out with why this is important. So the American Association of Medical Colleges has identified leadership as, quote, the most critical component for success. But every book, every TED Talk, every lecture at a business school, everything I've read to prepare for this starts out in a similar way, discussing the void in leadership, whether it's nationally, whether it's government, whether it's in business or anything. That's how they all start. So I guess my first question to you is, do you agree there's a void, and let's focus it on our area in hospital medicine or even pediatrics, do you think there's a void in leadership? Do we need more good leaders?
I definitely do. I think part of it comes from training programs, but part of it comes from, I think many people feel like they're not qualified to be a leader, and I think that's where we lose some people. Because I think there's not really a qualification to be a leader. It's more somebody who has a willingness to participate. It's probably 90% of it. It's really hard to find people that are willing to participate after they have busy clinical schedules and home responsibilities. To take on another responsibility is oftentimes the biggest barrier. But a lot of people would have a willingness, but they don't feel like they know enough or can do enough to be a leader. And I think that's probably not the right way to think about it. I think if you have a willingness to participate, the knowledge base will come. I always say that you choose for character and you train for skill. And so if you've got an interest and a willingness to participate, there's always going to be a place for you. In my current role, I'm the Vice President of Medical Affairs, which means I'm involved in a lot of the administrative decisions for the hospital. And I can tell you that when I was a clinical physician, starting out my career, administration was sort of this nebulous term, poorly defined. It was just this group of people in an office somewhere who were making decisions probably to punish me for something. But being on the other side, it's not the case at all. I think the 99% of the people that I've encountered in administration are well-intentioned and are trying to do the right thing, but they're also busy and they don't always have the physicians present to give their perspective, and they would love to have the physicians there to give their perspective. It's just hard to find those docs willing to come in and even just share opinions or share what the impact of decisions would be on clinical staff and patients.
That's funny because when you're on the wards and when you're taking care of patients, there's no shortage of opinions by doctors on everything. Go ahead.
Well, I was going to say that's one of the things that you, when you're trying to find physicians who you'd like to have participate, it's people who can be solution-oriented, I think is one of the most important things, because it's not hard to find people with opinions, but finding people with solutions, I think, or who are willing to at least collaborate on what solutions might exist or might work, I think is the important part.
Tom, you're unique in this leadership series we're doing because you are the only one we're interviewing who's from a community hospital. And you got into leadership at the community hospital setting. And I would imagine it's different than getting into leadership in the academic setting, where what you're being judged on is the papers you write, the grant money you have, the academic reputation that you have. I would imagine, and I don't know if I'm right or wrong, so I'm hoping you'll tell me, getting into leadership in the community hospital setting is different. That's not as much what you're looking for. Is that right?
Yeah, I would say in some ways it's less of a competitive track to leadership, and this probably varies across the country depending on the size of the community program, but most community programs have a single physician on at a time, so it's a group of 4 or 5 physicians that are covering the hospital throughout the week or year. So there's a limited pool of candidates to move into that leadership position, and that position may have an FTE attached to it, or it may be completely voluntary. So there's not as many people to vie for that position, and sometimes it's sort of the last person to say no is the one that gets selected for it. Sometimes there may be multiple people involved, and there's a decision that has to take place. But a lot of times it's more that there's one physician who kind of emerges that's willing to do it and is interested in doing it. In my case, I had a medical director who was over me, or that I reported to for the first 6 or 7 years of my clinical career, and she moved out of the area. And at the same time, this was towards the tail end of the financial crisis nationally, and there was a lot more scrutiny being paid to the finances in medicine. It seemed extreme then, but it probably pales in what we're seeing now. But our program was heavily subsidized by the hospital, and there was whispers about whether the program was going to be financially viable. I was young in my career and had young kids, and I took that leadership position partly out of self-preservation and partly out of seeing the good work that we did there as a group and wanting to maintain that as a service for the community. So I thought I would try getting involved and learning more about the finances of the program and what makes a program survive when other programs might not. And that's kind of was my first exposure to leadership.
That's interesting. So you had young kids. Hospital medicine is a young field. Did that leadership role at that level, your very first one, was that a big time commitment? Did that take you away from the things you wanted to be doing when you're done with the hospital a lot? For people who are listening who may be in that position who want to do that, maybe you can give them a little insight.
Yeah, I think it changes the nature of your time commitment some, and some of that depends on what kind of FTE, if any, you have structured for your leadership position. But I think there's sort of a curve to the time commitment. Initially, when you take the position, you're spending a lot of time because you're kind of getting up to speed. You're meeting with new people to introduce yourself and kind of getting situated, and then that kind of tails off a bit. And then there's a kind of growing curve as you become more skilled in your kind of span of responsibility, and you get involved in more committees, and people start to recognize you as the person they need to go to if they want to get something accomplished. It just sort of, it tends to keep piling up and up the responsibilities of the position. And that's when it's important, just for the sake of preventing burnout and maintaining your effectiveness to start taking stock of what kind of committees you're involved in, what meetings you're going to, which ones you're adding value to, which ones you're just sort of showing up to, and continually evaluate that.
Did you have any leadership training when you were starting out?
No, I would not say I did.
Did you ever get any leadership training, whether it's a course or even on your own?
I read. So when I was working through the Children's Hospital of Wisconsin, I read about Crucial Conversations, and I read different other books on leadership. And as I was taking on new projects, like starting a new hospitalist program, as you mentioned in the intro, I would work with some of our senior hospital leadership to learn about contracting and some of the things that are involved in establishing new service lines. But I don't think it was until I took this position that I had any formal leadership training, and that was mainly through going to conferences where you learned specific skills about joint commission and preparation and difficult conversations with physicians and things like that.
So it sounds like what happened to you is just you began getting in leadership roles, you were effective, you learned as you were going. It seemed to snowball. If you're a young leader or in a community hospital and you find yourself on committees and you find yourself participating and getting these leadership roles, at what point, or is there a point that you say, I'm going to need some time for this. Some of my time has to be now administrative and not just clinical because I need time to do all the stuff I'm doing. Or is that a conversation that happens to you, or do you have to bring it up?
I think it could go either way. I think probably more commonly you'll need to advocate for yourself, and that's when it becomes important to keep track of the work that you're doing and the outcomes that you're helping to achieve. Most of those times, administration want to see that there's a return on the investment that they're putting in you, that what you're doing in terms of work is achieving something related to growth of the hospital or improved outcomes or improved patient experience or improved retention of physicians or something tangible that's a benefit of the work that you're doing. So keeping track of meetings you're attending and knowing the specifics of the data that you're working with, I think is important to being able to advocate for yourself and establish the value that you bring to the organization or hospital.
Now, John Maxwell wrote a number of books on leadership, and in all of them he has the 5 pillars of leadership, but he talks about the reasons to get into leadership. And you alluded to this a little bit in the beginning in terms of why you should want to get into leadership. And people who get into it for the position title or the salary increase, it's always the wrong reason. He writes about it and then says the reason is similar to what you said, which is I want to make an impact, I want to help, I want to participate. Do you find in your position now that you're hiring leaders or you're interviewing people for different parts of the hospital, does that come through with people when you talk to them?
Sometimes you can get a sense of it. I do try when I'm talking to people that are interested in taking on a position to feel that out a little bit, because the title change and the salary change are exciting at first, and I wouldn't want to diminish the importance of either of those things, but I think anybody who's had a title or who's experienced a salary change would probably recognize that those do not become very noticeable in your day-to-day life for very long. And what you're left with is the work that you're doing. And so if you're not enjoying that work, if you're not feeling like you're making an impact, it's not going to be something that you're going to want to commit to long term. So I think just what you said, finding out why people are interested in the work is important. And it can't just be that you're good at it. It has to be that it is something you enjoy doing, and it brings you some personal sense of satisfaction to do it.
Tom, what's your definition of leadership?
You mentioned that when we were talking about getting together, and I don't know that I've ever really thought through what a personal definition of leadership is. I think mainly it's probably the trait of being able to influence, whether it's influence an outcome or influence a person, is probably what most of leadership boils down to for me.
Can you talk about experiences you had before you became a leader, from leaders that may have inspired you to do things the way you do? What does anything stand out?
Yeah, I think a couple things. One is I learned from the first medical director I worked with that that you're always going to hear complaints. It might be a complaint about an employee or a provider or the facility or something. And the people who bring the complaints to you are usually pretty charged up about them. If they felt strongly about it enough to seek somebody out to talk to them about it, it probably made a big impact on them. But what I appreciated her as a leader is that if it involved one of us, one of the physicians in the group, she would never make a judgment about that event or kind of throw us under the bus as providers without talking to us first to get our perspective. And I think that's something that really stuck with me is giving the person on the other side the opportunity to have their voice heard before you make any kind of judgment or assessment about it. And when that complaint is coming in, a lot of times there's a natural tendency to apologize and agree with the person. But I think you can diffuse a situation and you can acknowledge the impact that event had on a person without making a judgment about the provider that somebody's complaining about. And so I try to keep an awareness of that when I'm hearing something. And I would say the other thing is, I think in this current role, it's been sort of forced on me because I didn't know anybody at this hospital before I started. But I think leadership by walking around is important, and by that I mean I learned from somebody that they learned more from an afternoon or an hour of walking around the hospital than they did from most of the meetings they attended that day. And I found that if I walk around the hospital and just stop and chat with doctors and nurses that I happen to see that day, they'll tell me what's going on in the hospital. And I have a belief in servant leadership. So being first asking the person how I can help them before I ever reach out to them to ask what they can do for me. And so if they tell me that something's not working well for them, if they tell me that they're struggling with something, I try to be very responsive with that. And I think by doing that, by having a presence where people see you around and you've established a relationship where you're not just always asking them for something, where you're offering yourself, then when you do have to ask for something, whether it's a change in process or additional hours or participation in something, it seems to go over better. It's better received.
So you just answered two of my next questions, which is, one, what's your preferred leadership style? It sounds like it's servant leadership. Is that right?
I would say that's where I start, and you have to, or at least I've found that I have to adjust depending on the situation. But I think I try to start with that because I feel like I got into this feeling like I could make a difference for the doctors and patients here. And so I try to lead with that.
And then you adapt to situational leadership depending upon what's going on.
Yeah, if there's a doctor that's just not holding up their end of the bargain, then you can't just be there to serve them anymore. You have to have a conversation with them about what needs to change.
And then my next question was, and John Maxwell in all of his books also writes about trust and how a leader has to build and earn trust with those he or she's responsible for. And it sounds like that you kind of talked about how you do that, which is seeing how you can help, walking around, getting to know people, being a presence. Is there anything else you do to build trust with people so when you ask them for something, there's not an automatic groan?
Well, let me preface this by saying that I don't claim to be a perfect leader. I've been in this role I'm in now for about 7 months now, so I'm kind of learning as I go. But I think trying to engage people in the decision-making process whenever possible, I think helps to build that trust so that they know you're looking to them to have a voice in the solution. And I think some of that is on the leader to do, to seek out that engagement, but some is on the individual doctors to be a voice and to step up, because I've learned from many doctors that I've worked with that if you don't participate in the decision making, the decision's going to be made for you. And so if you at any point can get leader or physicians to start participating in the decision making process, they'll be happier with the outcome and more trusting of the process. And
you bring up another great point, which is one of the books I read for this was Extreme Ownership, a leadership book by a group of Navy SEALs. And I found it as a fascinating book, and one of the things they really discuss is mistakes. And they stress that leaders will make mistakes. And you have to, A, own the mistake, and be upfront, and be out there and saying it's my mistake, not the team's mistake, not that person's mistake, but mine, and then learn from it and not make it again. Can you, and one of the things I've noticed in medicine, I don't know why we we're getting better at it, but we don't talk about our mistakes very much. Do you have a story of not this position maybe, but a previous position you've had where you made a mistake in leadership and it taught you something?
Yeah. I'm going to try to be as vague as possible to not throw anybody any shade, I guess.
Sure.
That's probably not the best way to put it. But so in this current role, I work with many different specialty physicians, and there's a group of physicians who do procedural care, and they're somewhat competitive with each other. And one of the physicians worked with an outside group of referring physicians and was kind of talking up why they should send him their patients and not necessarily not the other one, but he was talking to them about why they should send him referrals for surgery. And in the course of that conversation, he said that he wouldn't send a specific type of patient to his partner because he didn't think he did as good of a job on that. And I heard about that, and I went and talked to the provider, and I told him that I thought it was not appropriate for him to be casting aspersions on another provider's surgical skills. But after I was thinking about that, and I was listening to a podcast, and they were talking about an event at a children's hospital that had to do with cardiac surgery, where there was a cardiac surgeon who had outcomes that were not as favorable as they should be. And the hospital administration and the people in the department didn't give it the attention that it deserved. And children who were coming trusting this physician for surgery were having outcomes that were not as desirable as they could be. And it kind of made me realize that while my intention was with meeting with that doctor was not to tell him to sweep any quality concerns under the rug, my intention was to get him to not sort of throw his partner under the bus. But the message I may have been sending, at least tacitly, was if you see something that's not right, keep your mouth quiet about it. And so I called him and I apologized to him and I said, I don't want you to get the impression that if you have a concern about something that's happening in the hospital, that I'm not receptive to it and won't act on it. So if you have any concerns, please bring them forward so that we can address it with the proper quality channels and peer review and things like that. But I think it just helped reinforce to me that when you're in a leadership position, people listen to what you say and they may read between the lines in ways that you don't intend. It's important to be cautious with how you present sensitive information and think from their perspective about how they might read that and what impact that might have on them.
I think that's the best example as an answer that I got for that question from everybody I've interviewed. So thank you for that. One of the common beliefs in any leadership lecture or book or anywhere or article is this idea of self-leadership. That before you can lead others, you have to be able to lead yourself. Self-awareness, self-reflection, self-regulation. Emotional intelligence has been big recently. Do you agree with this? Do you agree that to be an effective leader, you have to have a firm grasp on the self-leadership?
I think that's something to strive for, but I wouldn't want people to think that they need to achieve some standard of excellence that they might not feel is realistic for them before they can take on a role where they can make an impact. And so I think everyone who's in a leadership position should be trying to evaluate themselves and how they can continue to improve. But I wouldn't want people who are interested in making a difference to feel like they can't do that until they achieve some standard of excellence for themselves, because I'm not sure how many people have reached that Zen state where they feel like they get all those plates spinning at the same time in an organized fashion.
I'll be honest and say I'm not there yet. I'll be very upfront about it.
I'll send you an email when I get there.
Okay. Now, in hospital medicine, 50% of pediatric hospital medicine physicians are in community hospital settings. Roughly, that's the last statistic I've seen. How important is the pediatric hospitalist to a community hospital in terms of leadership, or in terms of committees, or in terms of just the running and functioning of a community hospital? How important is that pediatric hospitalist?
I think in many ways there's more opportunity and there's more importance on an individual pediatric hospitalist in terms of leadership than in an academic setting. And I say that because the department of pediatrics for a community hospital might be 4 or 5 doctors. And within that, you need to have somebody that's working with the obstetric and nursery providers on quality of care there. You need to have somebody that's working in the emergency room to make sure you've got proper warmers and proper protocols for pre-hospital care. You need to have somebody that's working on joint commission preparedness, inpatient quality care concerns. You need to have somebody that's in a formal leadership position that's working on scheduling and payroll and things like that. So you really need everything that you would potentially need in an academic center, with some exceptions, but you have a much smaller pool of people to work on it. So when I was at the Children's Hospital in a community setting, that was one thing we started is making a requirement that all the hospitalists need to take on some kind of leadership role in the hospital, and they could choose because there are so many options for two reasons. One is to get the work done, but also to establish the Pediatric Hospitalist program is something that is essential to the proper functioning of the hospital, because oftentimes pediatric hospitalist programs aren't financially sustainable on their own. So when administration is looking at areas of financial loss, they can look at areas like the chaplain program or social work or things like that don't add revenue, but they might also look at the Pediatric Hospitalist program. And when they do, I wanted them to look at them and say, well, that program might be costing us money, but that the hospital can't function without those docs here, both for clinical reasons and for leadership and administrative reasons, because pediatric hospitalists are too involved in the day-to-day function of the hospital to take it away.
That makes a lot of sense. If there's someone listening to this who's maybe, a resident or a fellow or even a young faculty member and says, I want to do what he's doing. I want to get into leadership in a community hospital setting I'm at and move up and I really want to do that. What advice would you give them?
I would say building relationships is important, and that's probably why I've taken on the roles I've taken on. So when we were expanding our pediatric hospitalist program from where we'd been for a long time, I got to know the leadership at another hospital that didn't have a pediatric hospitalist program, and really enjoyed working with them and getting to know them through creating that pediatric hospitalist program there. And when the outgoing vice president retired, they approached me, and it, to be honest, wasn't anything I'd ever considered. Working in adult medicine with adult medical problems and adult doctors initially sounded kind of terrible to me, to be honest. But then when I learned more about the position and the influence that somebody in that position could have in terms of improving the quality of care that every person walking through the door receives, and the patient experience that every person that walks through the door receives, and getting to know all the people who are doing really impressive work for adult and pediatric patients. That was kind of what sold me on it. So I don't know that I did anything to prepare specifically for this position. It was more building those relationships and continuing to learn new skills as a hospitalist medical director, so that the jump to this position wasn't as daunting as if I had kind of limited my scope of the work I did as a pediatric hospitalist to just one kind of small slice.
And when you say continue improving your skills, it's both clinical skills but also your leadership skills with your self-reading and self-education on the topic. Is that correct?
Well, that and learning more about what goes into the administration of a hospital. So learning about preparing for joint commission visit and learning what a department chair does in terms of OPPE and FPPE and credentialing physicians, and learning about quality improvement projects and working with staff that's doing the research and putting together data for you. I think it's those skills that the more of those that you can pick up, looking at financial reports and spreadsheets and budgets for a department, the more of those you can pick up, the better prepared you'll be for a position where you take on a larger responsibility.
The editor-in-chief of academic medicine, Dr. David Sklar, wrote an article in 2018. The title of it is Leadership in Academic Medicine, Purpose, People, and Programs. He makes a case in it for a better leadership development so that the investment of healthcare resources and leadership can be justified, and recommends this continual process of leadership development starting in medical school. And there's another article written, and I don't have the references in front of me, but it'll be on the references if you're doing the CME for the Armed Forces Medical School, that they have a leadership program starting from the beginning. Now, with all that physicians are being asked to do and having their own personal lives, do you think this is something that if we were taught more about leadership from early on, would this be beneficial to us?
For sure. I think there's things that are evolving in residency training and then probably fellowship training as that field of pediatric hospitalist medicine matures that are already improving. And I think of in my residency training, I trained 2005. I finished residency. At that point, we were still in the model where your first year you did a lot of wards, your second year you did a lot of PICU and NICU, and then your third year you were senior resident on a lot of those rotations, and you did a continuity clinic a half day a week. So my residency training prepared me really well to be a pediatric hospitalist, probably not so well to be a clinic physician. But I know a lot of residency programs now are stratifying the program depending on what your career aspirations are. And I think if you're going to be in a hospital-based specialty like hospital pediatrics, getting skills on how to run a meeting, how to lead a department, how to do quality improvement projects, I think is going to be pretty important. You're either learn it in residency or you're going to be having to learn it on the fly later. So anything we can do to add skills to people that are going to be needing them later, I think is really beneficial.
Tom, those were all the questions I had about leadership and about your rise through and as a community hospitalist into a big leadership position with both the adult and the pediatric side of the hospital, kind of under your charge. I guess my final question will be, then I'll give you an opportunity to bring up anything I didn't bring up. When you're evaluating somebody for a position, besides that conversation and the idea of why they're interested in the leadership position, what are you looking for in a person?
I think you want somebody who's got a genuine interest in making a difference. And so when you're asking them why they're interested in the position, trying to find out some specifics of what they're trying to achieve. Do they have ideas for the program or the department or the hospital, ways they feel like they can make a difference? Somebody that other people tend to listen to, and so seeing people in a group setting can be helpful. There's some people that start talking and you see people starting to look down at their phones or kind of look out the window, and there's some people that they start talking and everybody else is quiet and listens to what they have to say. I think that's a hard thing to know about somebody until you see them in action. But when I'm in meetings and I see somebody that has that command of the room and people really are listening and hearing what they have to say, that's somebody that it kind of raises my level of awareness of them as somebody that could make a difference in leadership. Because a lot of what leaders are doing is, like we talked about before, influencing other people and getting them to adjust their path a bit, whether it's in how they're practicing or how they're interacting or how they're documenting. So if we can find somebody that people seem to listen to and have ideas of where they could be an influence, I think that's what I'm looking for.
So, Tom, I've reached the end of all the questions I had. Is there anything you wanted to bring up that I didn't bring up?
Well, I guess the question I would have for you is you've had a few conversations like these with other people that are in a leadership position. Have there been any kind of big aha moments for you or any biggest takeaways that you didn't expect?
You're the first person to ever ask me a question on a podcast. I like that. I will tell you, everyone's answers from Dr. Ellen Wall, Dr. Terry Dermody, Dr. Jeffrey Sparing, Dr. Nancy Spector, some similarities that popped up were, one, they all said similar to what you said, which is join a committee in the hospital and do a good job, work hard with that committee, show progress, and then you'll get noticed for other leadership positions within. But all of them came to leadership a little bit differently. Jeff Sparing was in the military, and I think that really influenced his leadership ability because you get training in the military. Nancy Spector went through ELAM, which is a leadership program for women rising stars in academic medicine. Ellen Wald seemed to have found leadership accidentally, but she seems to be a natural leader. She's one of those people where I feel like I've never met her in person, only through the podcast, but even through the podcast, she has this presence about her where I would assume she commands a room, just by talking to her on the podcast. But they've all come to it for similar reasons that you said, which is they had a desire to help. They felt like they could do good for both patients and the physicians with them. So it reinforces to me that the people who are in leadership positions now are doing it seemingly for the right reasons and have our best interests in heart. Things may not always work out the way we want them to, but they all kind of agreed, they were all similar in that sense, but they all came to leadership differently. I don't know if that answers your question.
Yeah, no, I did. Thank you.
Well, I have to tell you, I've really enjoyed this conversation a lot. I appreciate your time. I know you took time out doing this, and I can't thank you enough. I think this is going to be a great episode. So thank you very much, Tom.
Thanks, Tony. It's nice talking to you.
Pardon me, sir. I'm sorry, I cut you off.
Oh, I just said nice talking to you.
Oh, nice talking to you, too. All right, now it's time for our acknowledgments. I would again like to thank our special guest for coming on the show. I would like to thank all of you for tuning in to PHM from Pittsburgh and letting us be a part of your day. I would like to thank, as always, the UPMC Children's Hospital of Pittsburgh, my division, the Paul C. Gaffney Division of Pediatric Hospital Medicine, for letting us do this. Of course, the University of Pittsburgh for their support and for the free CME credit to anyone listening. And as a reminder, the free CME credit is in the description of this episode on the podcast. Thank you, as always, to Dr. Megan Keene Tarchichi, who helps me with everything. Hey, I hope you all have a great day, and we'll see you next time.